Although cancer can affect anyone, factors such as race, income, age, and geographic location can lead to vastly different cancer experiences. And the pandemic has exacerbated these disparities in recent months. To discuss this and more, I'm pleased to welcome Dr. Gerald Harmon, who's president of the American Medical Association, and Dr. Karen Winkfield, executive director of the Meharry-Vanderbilt Alliance and a newly appointed member of the President's National Cancer Advisory Board. Really happy to have you both. Karen, I have become addicted to your Twitter feed and reading provocations that have such great clarity about some of the challenges. And as I was discussing, with our previous two speakers, I know that there are different dimensions of this. There's the research and the research agenda, what's coming on technologically, and we can kind of go into. The other thing is reaching people where they're at, and also those people where they're at. What do they trust or not in the system? Do they see themselves in the system? And you've been making that a kind of core foundational argument of your own that until we see more people, particularly from the community of color, in the healthcare system, we're going to have this gap in trust. Can you share with us a little bit more about your concerns?
Yes, well, thank you so much for having me. I'm so excited to be here, and you're absolutely right. This has been a passion of mine for such a long time. I mean, even when I was at Harvard, talking about the importance of having the people you're trying to reach represented on the teams. And look, I'm all about physician workforce development, but we need all team members. Like, who's picking up the phone at your institution? Who are people seeing when they walk through the door? What do your allied health professionals look like? And so that's an important component of helping to build trust, because you have people inside the system who are working for and with the system. But more important than that is really just addressing some of the things you've been talking about. Right. How do you build trust? Mm-hmm. And trust starts with being present in the community because it's the right thing to do, not because you need something, not because you need them to enroll on a clinical trial, but because you're truly invested in understanding what the populations are that you are trying to serve and what those population health needs are. I want
to go to Dr. Harmon in just a second, who's he runs the universe of in the American Medical Association is it's kind of like Oz, and I look at Dr. Harmon as sort of the Wizard of Oz. But I kind of look at this question, Dr. Winkfield. I just want you to tell our audience something that you wrote once about the difference in Boston of going from a Harvard University hospital to I think it was Boston City Hospital, and just the collage you saw.
Yeah, well, it was interesting because here I am. I'm a biochemist, and so I was very interested in doing some basic science research, looking at some of the disparities that we saw in cancer outcomes, but I couldn't get enough samples of Black women to do the research. And this is not a unique phenomenon. Biospecimen collection is under-resourced in certain communities. And what I didn't know is that Boston is a majority-minority city. And the reason I didn't know it, because here was my microcosm. I'm in the hospitals, in the Harvard hospital systems, and they're very homogeneous. And so it was fascinating when I did have an opportunity to do some training over at the city hospital, that's where I saw the Black and brown communities. So I think we need to look at the comprehensive cancer centers. And this is why I'm so excited to be a member of the NCAB, because I think this will be an opportunity for us to take a deep dive and a deep look into what's happening with the comprehensive cancer centers. I mean, how can you exclude people with Medicaid? Why is that okay when you're getting government funding? And so there are things that we can do institutionally that will really help to start to bridge some of these gaps in terms of the engagement and also helping communities feel that you are with them and for them to help build that trust.
Well, thank you. Dr. Harmon, in the world in which you're in, with the health practitioners that you have in this, and I've also learned in many of these forums that the stakeholders in the healthcare ecosystem in America are very diverse, from insurance companies to hospitals and doctors to there's pharmaceutical companies, et cetera. And I'm just interested because you've talked a lot about, as I understand, don't socially distance from your doctor, and you've also had an equity map, looking at race and division in the country. I'd like to know, at this moment of reflection, 50 years after the National Cancer Act, if we were to redraw some of those lines, what would be some of the biggest changes that you'd like to see make, and what could the AMA do to constructively push the nation, towards I guess greater inclusion and greater health outcomes across the board?
Steve, thanks for having me. You've nailed it. This is something the AMA has embedded in its in its core. Our mission is to advance the art and science of medicine and the betterment of public health. And that betterment of public health literally is half our mission, if not our entire mission. We're using the art and science of medicine to better public health. So to your point, and to the point you heard from Dr. Winkfield and before her, Dr. Mitchell, we have had outcome disparities among the Black and brown communities, minoritized communities in our nation for decades, if not centuries. So we have a very approachable target, a well-defined target that we can work on within American medicine to advance health equity and minimize and end health disparities. We can get there, but we have to take marked, defined steps with a plan, and AMA has a health equity plan to help address this.
Let me ask you a question. I in a previous life, I was an editor at the Atlantic magazine, and a colleague of mine, Olga Kazan, wrote a fantastic article about the zip code disparities in different parts of Greater Baltimore, that if you were born in one zip code, you were likely to live 20 years longer than another part just a few miles away. And I interviewed someone at that time, and Dr. Lena Wen at that time was the Baltimore Health Commissioner. I'll never forget that interview. It was fascinating. But as you looked at it, we had basically, I would say, the crown jewels of the health community in the greater Baltimore area, and Johns Hopkins and others. And we had patient advocates, and we had patients, real patients in the room, who were from these communities. And you would hear these were people trying to get over the stacked deck against them and had a hard time navigating. I'm just interested in your role as a citizen in charge of a big org. What can we do to change the way that there is stigma, depending on where you come in zip codes? There's stigma based on color and race. There's stigma. And I got to tell you, we had Johns Hopkins folks there that were looking at the community and vice versa and saying, we don't see each other. And so how do we overcome that gap?
Well, I'll step in right now and tell you what I think we have to do, and what the AMA thinks we have to do is educate. You heard that from others. We need to have an awareness that there is a problem. Dr. Winkfield said she was unaware that she was living in a majority underrepresented minority community. I mean, it's almost an oxymoron. But the data she was working on didn't tell her that. She became educated, and all of us need to be educated. The zip code disparity, absolutely. Here, I'm in rural South Carolina for almost 4 decades, and I see the zip code disparities depending on social determinants of health, where you live, what your insurance situation is, what your race is. So we understand that Charleston County, one county south of where I am, there's a 16-year life expectancy disparity. We're addressing that, trying hard locally and statewide to make that improved. So we need to educate each other. Then we need to get to the other point. We need to move with increasing trust among the recipients of these current health inequities. And so that they'll trust that we have their best interest in heart. We have access for them. We have fair and equitable access to health care diagnostics, screenings, in this case for cancer, as we're talking about today in the Cancer Forum. All these things have to be improved, but it has to start with education, appreciation, understanding, and then an executable plan.
Well, thank you for that. Dr. Winkfield, let me ask you this question. I lost my mother to breast cancer. She was from Tulsa, Oklahoma. Well, Bartlesville, Oklahoma, 35 miles north of Tulsa. And the truth is, when, she, I don't go into a deep personal story, but look, if you at that time, 15, 20 years ago, the doctors in Bartlesville gave her, one set of path. We moved her to Dallas. They gave her another path. Then we got her up to Baltimore, where Johns Hopkins, where it changed. And you could just feel that there was an unevenness in the cancer world and cancer profession. Now, I've talked to people now that things have changed, that there are these cancer pathways, and there are ways in which, doctors are being brought up to a consistent standard. But I'm interested, it's more than literacy. Literacy is the wrong word. And it's literacy both of the healthcare provision and providers, but it's also literacy of regular people who are scared. I'd just be interested in what you think we ought to do, because part of today is talking about technology. What can technology do to change people's lives, get early screenings, testings, increase the frequency and trust so that the interaction with the doctor is normal and routine? I just want to know how you would do it.
Oh boy, we could spend hours on that, and I know we don't have that time, but thank you so
But I'm
much
going to have you
for the
back.
question.
I'll have you
And
both
listen,
back. I mean, it's big. Give
Yeah,
me a
so let's
teaser.
just say,
Give me a little bit of a teaser.
Yeah. So Dr. Sharpless actually did talk about the importance of interoperability, right? The ability for one system to speak to another. And we do have that technology that's available. But technology is not going to heal the gap with respect to trust. It will not. And so just the way that you're talking about your mom, in Oklahoma, we know that 70% of the landmass of the United States is rural. And we know that that's another underrepresented and underserved community. So this is about socioeconomic status. This is about where people come from and the context that they live in. And Dr. Mitchell talked about the importance of prevention. But yes, that's education, but it's also access to prevention, right? So from my perspective, we actually need to take a step back as a country and say, what do we value? What is health? Health is not just the absence of disease. Health is the entire social context that people find themselves in. And that requires a much bigger and broader conversation. So I do agree with Dr. Harmon that education, not only of lay individuals, but of the healthcare providers and professionals and teams is really important. But we need to get in these communities and help them improve their wealth, because wealth is health.
Let me thank you for that. We're right near the end of our time, which I'm just going to say it sucks because this is really great. I want to go further with both of you, but let me ask Dr. Harmon and Dr. Winkfield this question. We've just been, I keep saying we've been through the pandemic. We're not through the pandemic. Pandemic is still very much raging in this country, raging around the world. I keep telling people that many of these healthcare issues are global issues. The cancer challenge is a global challenge, not just a national challenge. But I'm interested in your profession, Dr. Harmon, and what the morale level is. Do people still want to be doctors and nurses and practitioners in this space after we've seen frontline work? I mean, I have to tell you, I see a lot of salutes to frontline workers. I see a lot of people that are very pissed off that are frontline workers who feel left behind and neglected. What is the level of morale, and are you worried about that your profession, given what we've gone through and given the challenges we still have ahead?
Steve, before we had COVID, we had a concern about what we would call physician burnout. We had studies showing half of physicians, 40, 50% of physicians were experiencing signs or symptoms or professing a certain amount of burnout, fatigue, just concerns about their career choices, thinking about early retirement, thinking about withdrawing from active patient care and things like that. So we were already in that concern. Then we threw the COVID pandemic at the physician workforce, and they responded incredibly well. I call them my healthcare heroes, frontline workers, whether they're doctors, nurses, x-ray techs, they're all heroes. We thought we had it, as you said, we thought we were having a bit of a lull. Maybe the pandemic was in our rearview mirror, and then bam, we're up with the Delta variant, new transmission rates, new deaths. And I still work on the front lines these days, both the inpatient, the ICU setting, as an internal medicine, family medicine doc. And I work with these folks, and I see these young doctors and the other healthcare workers now seeing a little bit of battle fatigue. They're emotionally drained, physically drained. They're getting fatigued. None of them are getting angry, however. I don't see anger. I don't see disrespect for the unvaccinated. I do see a bit of battle fatigue, and so I think it's in there. It's in their DNA. I told them when I became president, I want us to remember our why. We took an oath to do the best we can with the gifts we have to be healthcare providers. But we're getting stressed a little bit, so I'm concerned about their emotional and a bit of their battle fatigue, yes.
Dr. Winkfield, I'd love to hear from you, your thoughts on the level of morale in your profession.
Yeah, so look, we are seeing real fatigue from across all different types of healthcare providers. I'm a radiation oncologist, and they're asking me to staff an ICU. That is not the best use of my time. And trust me, it's not best for patients. And so I do kind of feel like there is fatigue, and I worry about mental health. We know that physician suicide rates are astronomical to begin with. And so this is only going to exacerbate. I must say there are some wonderful clinical trials. I'm involved with the HERO research program that's kind of coming out of the Duke DCRI at Duke University. And I tell you, there's long-term, there's going to be lots of issues. But I really want to appeal to everyone. Please do your part. Some of this was avoidable, right? And to Dr. Harmon's point, we're going to treat you. You walk in the door, we're going to treat you. But if there's any way that you can see your way to say, look, I know this is not just about me and my right, but I want to protect the people around me. I want to protect my loved ones. I want to protect the healthcare workers, because when you get sick and you come in, that means we don't have beds for people having a heart attack, or we
Right.
don't have beds for cancer patients. I actually had one of my friends call me who's got metastatic cancer saying, I can't get a bed. I'm sitting in the emergency room for 2 days waiting for a bed because they're filled with patients with COVID. So
Wow.
please, please, please do your part, folks, and help us get over this pandemic.
Can I just put a placeholder in for a future conversation with you both? This has been very real and very cool. I really appreciate your time and your candor. Dr. Gerald Harmon, President of the American Medical Association, Dr. Karen Winkfield, Executive Director of the Meharry-Vanderbilt Alliance, and she's a member of the National Cancer Advisory Board. Thank you both for joining us.
Thank you.
Thank you very much. Honored to be with you.